So just to talk about this image, we see the basic carotid anatomy, so common carotid artery at the bottom. And as you see, the divides into the external carotid and internal carotid, with the internal carotid usually posterior to the external carotid artery. So the measurements are all based on the study from 1991 that had a very specific way of measuring the caliber of the vessel. And it was based on this parallel walled segment would be the denominator, and we would pick the narrowest segment. So for example, in this angiogram, this would be the parallel walled segment. So we would pick one, this would be our denominator dimension, and this would be our stenotic segment. Now, the reason that was done as a percentage, of course, is that in those days, with conventional angiography, or now digital subtraction angiography, there is a magnification effect that goes on. So we didn't actually have absolute values. So it was done as a ratio, which is clever and broadly applicable. But with CTA, of course, we now have ways of measuring in increments that are reliable. And so as you pick the narrowed segment, for example, here, you want to come into it perpendicular. And I usually try to reconstruct this on Terra Recon if I have any question. But again, you're measuring the narrowest segment. So one way to bypass this notion of the NASIC criteria is to decide how to measure a cross-sectional vessel. So here you see the cross-section of a vessel. We'll say the yellow is the atherosclerotic disease, the white would be the lumen. And so I would ask, which way would you measure? Do you measure the area, which of course you can do on CTA? Do you measure like a combination of multiple dimensions, or you just measure the shortest dimension? And so based on the NASIC criteria, you really should be measuring the narrowest dimension in the vessel, because that would be what you would see on the projection from angio. Now, this was sort of simplified, I think, and you should be aware of this paper, is that we can bypass some of the measuring and some of the errors in measuring by just measuring the shortest dimension on CTA. And so the important thing to recognize is, how do we decide where to measure the vessel? So the first thing you want to do is window the vessel so you can roughly see the wall of the vessel separate from the fat. And then you want to put your cursor in what's called the gray of where you see the vessel wall would be. So we're going from the middle of the gray to the middle of the gray. We're not going from the edge of the white, or we're not sort of adding the whole vessel in. And so in this patient with a stenosis, you get a dimension of 3.2 centimeters. Now, this table is something to keep in mind. You don't have to remember all of these numbers, but it's actually a little surprising when you see a patient on CTA who looks like they have a significant stenosis, and you get a measurement of, say, 2 millimeters, which looks pretty narrow. That correlates with a 54 to 59% stenosis. And you have to get all the way down to 1.3. So if you want to choose that number on a CTA, if you see a dimension of the vessel that measures 1.3, that's the 70% threshold. And I can tell you that actually looks very narrow and difficult to measure accurately. So again, don't overestimate the degree of stenosis and sort of fudge the numbers to sort of match your previous pre-opinion about how narrow it is. But when you calculate the stenosis, of course, we're using the assumption that the distal vessel is normal. So, but the things that can alter the way the vessel looks, one is diminished inflow or outflow. This leads to a collapse of the cervical carotid artery. And as you know, in some cases gives you what's called a string stenosis of the carotid. And that's a 90% stenosis or greater. But there are some normal situations where the carotids can be asymmetric. One is if the A1 segments of the ACA are asymmetric, specifically if you have a hypoplastic A1 segment, then one of the carotids will carry pretty much all of the anterior circulation, sort of both the anterior cerebral arteries, where the other one only carries flow to the middle cerebral artery. The other possibility is that you can have congenital carotid hypoplasia, and we'll talk about how you can make that diagnosis. And then finally, another pathologic condition are dissections. So I'll try to go through these. So here's a patient you can see on this surface model of the CTA, and here's the distal internal carotid on the left, distal carotid on the right. Remember, we're not looking from the feet up as you do on a CTA, we're looking from the top of the head down. Here's the normal A1 segment. Here's the anterior communicating vessel. And this single vessel and this carotid are supplying both the anterior cerebrals because there is no supply coming from this carotid artery. So this is a hypoplastic A1 segment. And as you can see, the distal ICA looks a little smaller on this side than on this side. Now let's take this case. Here you see that on the MRA, there's a flow void in the right carotid and very narrow or absent flow void on the left side. So before you assume this is a string stenosis or occluded carotid, you should consider the possibility of hypoplasia. So the patient went on, had a CTA, and here you can see on the CTA, this is the normal carotid canal. This is the caroticojugular spine. Here's the jugular bulb. Now, if you look on the other side, here's the jugular, and there's like this tiny channel. So if the bony canal is narrow, that tells you that carotid was never normal size. And so we can make the diagnosis here of a congenital hypoplasia of the carotid. Don't confuse the carotid canal, of course, with foramen ovale. Now, let's look at this CTA. So you'll notice on this slide, of course, that here's the left carotid artery and the right carotid artery, and they should be within 1 millimeter in size with each other. So when you have a carotid that when they differ in greater than 1, and once you get to 2 millimeters in difference in size, you have to consider these possibilities of either a flow-related collapse or a hypoplasia. In this carotid, as we'll go up, here's common carotid artery on both sides. Even the commons are different size. Here's the proximal ICA on this side, right? Here's bifurcation. Here's bifurcation on this side. Now we're comparing this carotid to this one. Well, this is a huge difference in size. So let's look at the upper part of the CTA in this patient. So again, here's the normal size carotid canal. Here's the diminutive carotid canal on this side. So again, this is another case of carotid hypoplasia. Now, how often will you see these? I mean, I see in my practice over the years, I've seen a lot of CTAs, and I think we see these once or twice a year, but often enough that you have to be aware of it so you don't start a whole workup for carotid dissection and string carotid from a proximal stenosis. Okay, so that's carotid hypoplasia. Now we'll look at this case. We can see in this case that the patient has a larger carotid on this side than on this side. As we look up into the skull base, we don't see much difference in the size of the carotid canals on this section. So in this patient, this is a string stenosis. I didn't show you the cervical imaging, but if you have a carotid this size without any soft tissue around the carotid artery and no real difference in the bony canal, then you have to assume that the carotid is narrowed so much at its proximal segment that you have a 90-degree stenosis. Here's another case. Here we have asymmetry in the size of the carotid, left and right. And then if we look, we notice that this is kind of backwards in the sense that this carotid disease is worse on the left side. This is the left side than the right side. Here's the proximal ICA. So there's another possibility that you should consider is that not that the inflow is abnormal on this side, but that the outflow is abnormal. And if you look carefully past this calcified cavernous carotid artery, you see that you don't see any carotid artery. Here again, we see the surface model of the carotids, and this is what the maximum intensity projection reconstruction. I made this on Terra Recon. It shows you there's actually a stenosis on the left side and occlusion or near occlusion on the right side. So be suspicious in patients who have asymmetry and you don't find any proximal reason for it. If the patient doesn't have a hypoplasia, you want to consider the possibility of a distal stenosis or occlusion, which would be another reason why the patient's carotid artery would be small. Now, I think in this last segment, I'll show you some pathology. This is a typical appearance of a carotid dissection. And this differs from a carotid stenosis in that the narrowing is away from the proximal ICA. And it has this tapering flame, or some people call it a rat tail appearance if you have a little string coming out of it. But this is a typical appearance of a carotid dissection. Now, these can be traumatic, these can be spontaneous. Sometimes we're not quite sure, but I think in the end, this is a diagnosis you should be able to make from the CTA or angiography. Now, in this patient, we were looking at the carotid artery because the patient presented with multiple infarcts actually here in a watershed distribution. So the implication here would be the patient has poor collateral flow, and we have diminished inflow coming from the ICA, so that the flow from the ACA and the MCA, they drop off here in what's called the watershed between those two vascular territories. Here's another case, and I want you to recognize that in a normal patient, if you have a normal sized carotid canal and foramen, the carotid should fill that vessel. If the carotid is hypoplasia, is plastic, the foramen should be small. Now, you may be aware that that differs from the vertebral artery, because you'll see cases where the transverse foramen looks larger than the vertebral artery. So for whatever reason, whatever way you think about it, the foramen match with the carotid, but don't match with the vertebral artery. So in this case, you have to explain why the carotid doesn't fill the foramen, and I'm going to give you this other history that the patient has a left-sided Horner's. Here on the MRA, you can see that here's the flow void on the right side, and there's something that matches in location with this, and this is the false lumen. So again, this is thrombosed blood in the false lumen. Here's the patent lumen. Here's the reverse on the CTA patent lumen. This is the thrombosed false lumen. And so keep that in mind, that is, you'll have in the, let's say we're looking at the carotid artery or the carotid in its horizontal canal, you'll have the thrombosed blood in the false lumen, and you'll have a patent lumen separate. Here's another patient. This one you can make the diagnosis of the carotid dissection based on the appearance of the wall of the vessel. Normally you see a thin wall around the vessel with fat around it. This of course is not the carotid wall here, but in this one, this looks like the carotid artery, but it looks like there's something filling a portion of the carotid artery. So again, this is another case of carotid dissection. This is what a carotid dissection looks like in angiography. And again, you can see that the occlusion takes place distal to the carotid bifurcation. And we have this tapering, rapid tapering into a symmetric small channel. So again, typical appearance of a carotid dissection. So when you see one small carotid artery, I mean, this is the drill I go through on these cases. You want to think about a proximal or distal occlusion, or it can be a severe stenosis. You want to think about normal causes of asymmetric flow. This has to do with vascular variants in the brain. You want to think about carotid hypoplasia, and this one you should be able to solve pretty easily if you have a CTA. If you don't have one, you probably want to get one if you think it's a possibility. And then finally, ICA dissection. So that's my discussion I wanted to give you today, talking about a common problem. And I'd be happy to take any questions right now.